Good morning. Today's class is about post-modulation. Coming on to the history, the birth of the concept of post-modulation was in 1990, and it was given by Ray C. Williams and Lon Gollo in 1990. Post-modulation is aimed to control the destructive aspects of the host response in the periodontal disease without compromising the host immunity. When we see the linear bacterial model of pathogenesis of periodontitis in 1960s, it depicts that the bacteria have a principal etiologic role in the initiation and progression of the periodontal disease. When coming to the SIRPA model in the 1980s, it emphasizes that there is a central role of the host immune inflammatory response in the clinical development and progression of the periodontal disease. When coming on to the nonlinear model in 1997, it demonstrates various contributing factors for the pathogenesis of human periodontitis based on the pathways and processes known at that time. That is, whenever there is a microbial challenge, there is antigen and lipopolysaccharide and other virulence factors are present, which initiates the post-immunoinflammatory response. And by then, from post-inflammatory response, we have the cytokines and prostanoids and the MMPs, matrix molecular proteinases, and this causes the destruction of the connective tissue and the bone metabolism, and there is a clinical sign of the disease initiation and progression, and which has an environmental and acquired factor and the genetic factor. Coming on to the host modulation therapy, when we see the host is the organism from which a parasite obtains its nourishment, and modulation is the alteration of functions or status of something in response to stimulus or altered chemical or physiological environment. Post-modulation therapy, by definition, HMT is a treatment concept that aims to reduce the tissue destruction and stabilize or even regenerate the periodontium by modifying or downregulating the destructive aspect of the host response and upregulating the protective or regenerative responses. The rationale behind the post-modulation therapy is that HMT is a means of treating the host side of the host bacterial interaction, and HMTs do not switch off normal defense mechanisms of inflammation. Instead, they ameliorate the excessive or pathologically elevated inflammatory processes to enhance the opportunities for wound healing and periodontal stability. The potential targets for post-modulation are, as we see here in the back, we have the bacterial component, the host response component, and the clinical sequelae. In the bacterial component, out of these bacterial products, we can have antimicrobials as our mode, and our target is the bacterial products. And in host, our targets are the PGs, cytokines, and MMPs, and our bone response and both the resorption and connective tissue breakdown, we have the osteoclasts. These are all the targets where we can reduce the progression of the disease and enhance the reparative capacity of the host. You can see here, we have explained this pathogenesis model, and the classification of the agents of post-modulation are systemically administered agents. There is the non-steroid anti-inflammatory drugs, NSAIDs, bisphosphonates, and sub-antimicrobial dose of doxycycline, that is SDD. And locally administered agents are non-steroid anti-inflammatory drugs, NSAIDs, enamel matrix proteins, growth factors, and bone morphogenetic proteins. Coming on to the NSAIDs, a characteristic vasoactive fatty acid from human seminal vesicle fluid capable of decreasing the blood pressure in rabbits was first described by von Euler in 1939. This product was named as prostaglandin, and this is formed with arachidonic acid and COX mechanism, and we have COX-1 and COX-2, and it is derived from these fatty acids. The activity of the pyrogenicity, vasoconstriction, vasodilation, increased vascular permeability, contraction of smooth muscles, chemotaxis of phagocytes, and platelet aggregation. And these are all the lipid mediators. There is the PGE2, thromboxane A2, PGIE2, PGE2, PGD2. All these are the lipid mediators. The pro-inflammatory prostaglandin, there is the PGE2. It is in the presence, whenever there is a presence of lipopolysaccharides, and it is produced by the neutrophils, macrophages, and fibroblasts. It induces MMPs, that is matrix molecular proteinases, and stimulates osteoclasts. They have been shown to be elevated in patients with periodontal diseases compared with the healthy patients. PGE2 inhibits fibroblast functions. And coming on to the classification of NSAIDs, salicylates are, we have these classifications like salicylates, pyrazolone derivatives, indole derivatives, propionic acid derivatives, anthelinic acid derivatives, arylactic acid derivatives, oxychem derivatives, and pyrrole derivatives. And these are all the drugs. There is aspirin, phenylbutazone, indomethacin, ibuprofen, naproxen, mefenamic acid, diclofenac, pyroxicam, and the ketorolac. Based on the animal studies done by Nyman et al., William et al., Jeffcoat et al., William and et al. In all these years, it is stated that these NSAIDs have a very good impact on this reduction of these pro-inflammatory cytokines. And we even have a lot of human studies done by Jeffcoat, Heisman, Fleming, Pressure, and Budinelli et al. A daily administration of the major side effect as such is a daily administration for extended period of time is necessary for the periodontal benefits to become apparent, so which enhances the hemorrhage due to the antiplatelet activity, gastric ulceration, renal failure, and there will be a rebound effect, and there will be side effects of the COX-2 inhibitors. Coming on to the bisphosphonates. Bisphosphonates are commonly called as the bone-seeking agents, and the most commonly used bisphosphonate is alendronate. This increases the osteoblast differentiation and inhibits the osteoclastic recruitment and osteoclastic activity. They interfere with osteoblast metabolism and secretion of lysosomal enzymes, and they even have anti-collagenase activity. Widely used in the management of systemic metabolic bone disorders such as trauma-induced hypercalcemia, osteoporosis, and Paget's disease. The actions of bisphosphonates are in tissue level. They decrease the bone turnover due to the decreased bone resorption. They decrease the number of new bone multicellular units, and they have the net positive whole body bone balance. In a cellular level, they have a less, or they have reduced osteoclastic recruitments. They have increased osteoclastic apoptosis. They decrease the depth of resorption site. They decrease the release of cytokines by macrophages, and they increase the osteoblast differentiation and number. Based on the human randomized control trials, it is significant that there is an improvement in the periodontal probing pocket depth of all the clinical parameters by use of bisphosphonates. The drawbacks are the long-term use may suppress bone turnover and compromise healing of even the physiologic microinjuries within the bone, given by Orbina et al. In 2005. Clinically, bronch avascular necrosis of jaw, that is bronch, is essentially exposed bone in the maxilla or mandible that does not heal within 8 weeks of identification, is proven by Wang H.L. et al. In 2007. And patients with previous dental problems might have a higher risk of osteonecrosis of the jaw. They inhibit bone calcification and induces changes in WBC, and hence the bisphosphonate drugs are approved in treatment of periodontal disease. Coming on to the SDD, that is sub-antimicrobial dose of doxycycline. It was used in the mid-1980s. And when we think of doxycycline, why did we opt for doxycycline is that doxycycline tends to be a highly concentrated GCF at levels 5 to 10 times greater than the serum and shows substantiality as they bind to the tooth structure and are slowly released as they are still active agents, as per Pascal et al. In 1986. And the first clinical study prescribing SDD as an adjunct to the mechanical debridement showed statistically significant reduction in GCF concentration of MMP8 and MMP13. MMPs are the zinc-dependent and calcium-dependent proteolytic enzymes, that is proteinases, which are responsible for remodeling and degradation of extracellular matrix components of the collagen. They are the family of zinc and calcium-dependent endopeptidase secreted by a variety of host cells called as PMNS, macrophages, fibroblasts, osteoclasts, epithelial cells, and endothelial cells. The predominant MMPs in periodontitis is PMN-derived MMP8, MMP9, and which degrade the type 1 collagen, which is abundant in gingiva, and PDL fibers. The mechanism of action of these STDs are, it inhibits the production of epithelially derived MMPs, It has a direct inhibition of active MMPs by cation chelation, inhibition of oxidative activation of MMPs, downregulation of pro-inflammatory cytokines, that is interleukin 1, interleukin 6, PGE2, tumor necrosis factor, and it scavenges and inhibits the production of ROS, that is the reactive oxygen species, and it stimulates the fibroblast collagen production. It reduces the osteoclastic activity and bone resorption, blocks the osteoclast MMPs, and it stimulates the osteoblastic activities and bone formation. SDD is approved by US FDA and ADA, and it is commercially available as Periostat. The sequencing prescription with periodontal treatment is, it is not used as a monotherapy, and it is used as an adjunct to SRP. It is taken as 20 milligram twice daily for 3 months and up to a maximum of 9 months of continuous dosing. After initial periodontal treatment, the patient is enrolled into an intensive maintenance program for the reevaluation of the probing depths, reinforcement of oral hygiene, SRP, remotivation of the patient. The need for continuing the STD can be assessed. Then we are coming on to the locally administered drugs. That is, the NSAIDs are the topical ketorolac molecules where the GCF level of PGE2 is reduced over half for more than 6 months and the bone loss has been halted. Locally administered ketoprofen has also been used. The enamel matrix proteins are used which stimulate the regeneration of lost bone, periodontal ligament and cementum, which is the endogain. And we have the locally administered growth factors PDGF and ILGF and BMPs 2 and 7 and recombinant human PDGF-BB, which is GEM21S, and recombinant human BMP2, which is infused. The currently approved FDA is the endogain, GEM22S and infused. The newer host modulatory agents are the CMT, that is the chemically modified tetracyclines, which have the non-antibiotic property and they retain their host modulatory and anti-collagenollytic effects. CMT3 and CMT8 has anti-MMP properties. The anti-cytokine drugs which manage the rheumatoid arthritis, TNF alpha antagonist, that is the infliximab, etanercept, and interleukin-1R antagonists are all used. The PESBins, that is the polyenolic zinc binding components, are also used. And in herbal modification of curcumin, that is CMCs, has the anti-inflammatory properties which inhibit MMPs. Recently, the stem cells have also been brought into the view and are being used. Coming on to the conclusion, post-modulatory therapy is always beneficial for periodontal diseases and treatment. So, thank you.